Bismillahirrahmanirrahim. Alhamdulillah, wassalatu wassalamu ala Rasulillah. First of all, I would like to thank the organizing committee for their kind invitation to be part of this conference. Please, if you're not registered for the workshop, there are only 30 people registered for the workshop. So please, you could have your lunch. There is registration. There are only 30 people registered for the workshop. That's the number. There is a registration. Okay. ممكن نبدأ بس ما أقدر لأنه بدي أغش. Oh, okay. Yeah, it just. So please, if you register, just come to the front so we could know who's in the workshop. Who's here from anesthesia? ICU? Okay, nurses? Technicians? Okay, so my name is Abdulaziz Booker. I'm a consultant anesthesiologist from King Abdulaziz University, associate professor at the Department of Anesthesia and Critical Care. Also, I work in education. I'm the Dean of Medical School in Yambo Royal Commission in Yambo City. This is a workshop. Usually we give it over 3 or 4 or 5 or 6 hours. Today will be a workshop in a capsule for 1 hour. So we'll just need to go over the material. So instead of going through Jeddah or Riyadh in 1 hour or 2-3 days, we'll just take you and give you an overview over the whole airway management. Okay? But if we want to have a hand-on, everybody wants to practice every tool in the stations and master it, you might want to consider to come to a full workshop for difficult airway management. Okay? So who should usually come for difficult airway management? Everyone. Like who? Anybody who attempts intubation. So why not only anesthesia or doctors? Because emergency does not wait for anybody. And that's usually what happens. It could happen at the middle of the night, and your first assistant, and maybe your second or the only assistance you have, is your technicians, nurses, surgeons, other people in the ICU or in ER. So when we give this difficult airway algorithm management for difficult cases, we want to make sure that enough people in the team knows what's going and what needs to be done in these cases. So you will have to have more than one person who could really help in these situations. So what we'll do, we'll quickly go over the difficult airway algorithm, and then in the last half an hour, because they already have eaten half of our time here, half an hour of our time for the workshop, they did not evacuate the hall. The last 30 minutes we'll spend in hand-on with the fiberoptics. We'll just give you a sample of the equipment here. So the main talk or aspect that we'll cover is the difficult airway, ASA difficult algorithm. We'll start with definition of term, assessments, the ASA algorithm, and then maybe we'll talk a little bit about tools. Of course, difficult airway algorithm or difficult airway, it's usually different people see it differently. Some people, if they just try to intubate one time, they say it's a difficult airway. Some people might try 3 times and they say it's easy airway. So to make definitions very clear, the first thing was just to establish the definition of difficult intubation. It's either difficulty with ventilation or with intubation, or both. Is intubation and ventilation same or different? What is more important? Sorry? Okay. Democracy. It's now democracy movements, okay? So if you think intubation is very important, raise your hand. Intubation. If you think ventilation is more important, raise your hand. Okay, why? That's the correct answer. Democracy is a good thing today. Why?
Because intubation is not the only method to ventilate the patient.
Okay, so intubation is not the only way to ventilate a patient. And what else?
The purpose of intubation is
Sorry? Okay. Okay, so it's completely okay. But if you can't get intubation, do you need to insist on intubating? Okay, this is a point that will come back, because this is why a lot of patients with difficult airway die, because people don't differentiate between intubation and ventilation. They think intubation is very important. What does intubation provide that ventilation does not provide is airway securing the airway from aspiration. How many people could die if they aspirate? If somebody aspirates, what's his chance of dying? Worst case scenario, 20%. But if they're not ventilated, their chances of dying is 100%. Okay? So, in a lot of cases, people insist to intubate, and then they kill the patient because they will lose ventilation. I will talk about that in brief. So this is definition of difficult mask ventilation is inability to reverse the signs of hypoxia or a signs of lack of ventilation. The chest is not moving or saturation is dropping. Difficult laryngoscopy cannot visualize any part of the glottis. That's grade 3 and 4 laryngoscopic view, and we'll come explain that with picture in a few minutes. Difficult intubation, proper insertion of tracheal tube take 3 attempts or more than 10 minutes. Okay. Of course, when this difficult airway algorithm came out, the reason was there are a lot of cases dying because of difficult airway. So the American Society of Anesthesiologists made a task force and they reviewed the literature. And there is a strong evidence that there is specific to improve management of difficult cases. It's like having basic life support and advanced cardiac life support on ATLS and NRP and these things. There is very specific methods to improve outcomes after difficult airway. And it's yet need to be reported that in one place, if there are 2 people who know the algorithm very well, the patient will die. If there are 2 people who are very well trained in difficult airway management and the patient died because of difficult airway, that will be a reported case because it's never happened. If there are 2 people who knows this stuff and know how to apply, it never happened. So having more people trained and aware is very important. So this is the way that we start assessment: history, physical examination, and other investigations. The things in the history, those are the predictor of previous difficult airways, previous diabetes, ankylosis, arthritis, clotting abnormalities, congenital syndromes. Some of those are very obvious pediatric rare congenital diseases, anything that restrict mouth or neck mobility. Of course, problems with the nose is very important. Why is nose very important for difficult airway management? Sorry? Because half of the solutions go through the nose. A lot of people have problems with the mouth and they just focus on the mouth, while the nose could provide a lot of solutions for difficult airway management. TMG joint, how many centimeters the patient could open their teeth. Is that important or not important? If I tell you that the patient is difficult airway and his incisor difference between his teeth 2.7 centimeter, what is that? Is that important or silly information? Why? Why that information is very important? The patient, sorry?
The laryngoscope.
So laryngoscope will not but what's management? So see, laryngoscope is out. So what other information that are very useful for information? Sorry? So you could think of using the nose. Then, as will come in few minutes, how many options you have to manage difficult airway? Maybe 25, 26 options, okay? So you need to know which of the 25 options are out. Laryngoscope is out. Fiberoptic, is it out or in? In. Retromolar, is it out or in? What about LMA, laryngeal mask airway? Out, raise your hand. Yalla, Rudy. N, fast track. عارفين fast track? A rigid LMA, fast track. Of course, LMA, that's a tricky question. You know, I'm testing you before lunch, you know, that's very unfair. Because there are 6 different types of LMA. Okay? Not all LMAs are LMAs. There is rigid and soft. The soft ones that are compressible, you could pass it even down to 2.7 millimeter. The ones that are hard, like the fast track for intubation, is not flexible, so it does not go. That was a trick question, but mashallah, you're awake. By the way, I am anesthetist, so if you fall asleep at any time, that's okay. That's part of my job. Okay? So don't feel embarrassed. If you had a good lunch, feel free, okay? And of course, if you snore, the fiberoptic is here. We'll have a candidate, so feel safe, okay? So examination, other features for difficult airway. Then the neck movements. This is the laryngoscopic view. This is, you know, the nickname for this, Malapati scoring. And then this is the laryngoscopic view. Is this something useful?
Very useful. Very useful.
Okay. Yes, raise your hand. No, your hand. Okay, it's yes or no. So if it's class 1, it's very predictive of easy intubation. The laryngoscopy will be very easy. If it's class 4, very difficult. It's very useful. But if it's intermediate, if it's monopathy 2 or 3, it's very useless. Because if monopathy is intermediate like this, the patient could have type 1, type 2, type 3, type 4, or stage 1, stage 2, stage 3, laryngoscopic view. So in extreme cases, it's very useful. In borderline cases, it's useless. So it's yes and no. There are a lot of scoring systems in the literature, and you could just add scores. I don't really care about that. This is the old ASA difficult airway algorithm. This is the first one. Okay, how many steps in this? How many major steps? 1, 2, 3, and there is a small box and then big box. And step number 1, how many sub-steps? This is an eye examination. In ICU, you have a very good eye, so this is a part of your eye exam. If you can't read this very clear, you know. So how many steps in number 1? 3, okay. So this is the new algorithm. So how many steps overall? 4. How many steps in number 1? 4. Okay, so it's 4 and 4. Now, what did they add it? Okay, we'll go over them all in details, okay? So the first thing, assess the likelihood. You need to differentiate between the 4 steps. Is it difficult intubation, difficult ventilation, difficult consent or cooperation, difficult with tracheostomy? Because we know this is what they added. Because some patients, it's very difficult, even tracheostomy, because before when we say, okay, difficult airway, they say just get an eye. You know, like if you talk to surgeons, they say, like this. Remember the latest case that was in the news in Saudi Arabia, the doctor who died in Jeddah, one of the private hospitals? What did they do when it was difficult? Did they do tracheostomy? It did not even come on their mind. The patient died in front of them and they did not even think. So this is not a joke. You need to consider the 4 options before we start. That's number 1. Okay, million litigation against the doctors. Of course, everybody who is involved in the team is out of business, because this is no joke. ICU, anesthesia, surgeons, and the hospital is out of business. So this is no joke. This is the second one that is very important. Step number 2. Actively pursue opportunities to deliver supplemental oxygen throughout the procedure. You will see with intubations, once the doctor is intubating, everybody else doing something useless. Somebody needs to hold oxygen against the patient's face. That will improve and decrease the chances of desaturation. That's a very critical step. Somebody of the team, either the doctor or the senior or the RT who's intubating, need either to instruct somebody to give oxygen or to somebody else to do it. But this is a very important part of the management, to keep oxygen near by the patient face. Then we have to ask, should we go for awake intubation, or we induce anesthesia, or go to non-invasive airway management or invasive airway management, and then we could go either spontaneous ventilation or we stop spontaneous ventilation. Where should we go? What's the safest? First column or second column for difficult airway cases? Should we go here or here? Okay, democracy, another democracy. ححرمكم بالديمقراطية. زي السادات ما قال. Sorry? No, there is no question, but we need answer. So, where should we go? Here or here? Okay, first column, raise your hand. Second column, raise your hand. And everybody say we win, we want democracy, ladies want to vote, and when we ask them to vote, nobody votes. Okay? We'll repeat. I need to see all hands moving. Even if you sleep, the person next to you, please raise his hand, okay? Because I need to know, you can't be on the side, you can't be in the middle. This is difficult airway, you need to take sides, okay? So if you're here, raise your hand. If you're here, raise your hand. Still, there's a lot of people sleeping, nobody. But the problem is the sleeping people together. So we need to maintain here. Awake intubation without the abolition of muscle power and without non-invasive. Because the key aspect is that if you induce anesthesia and the patient is not breathing, you have only 5 minutes to secure the airway. If the patient is awake and with his spontaneous breathing, you could practice or do your awake intubation or intubation in 5, 10, 15, 30 minutes. You have a lot of time. And time is very important, you know, like that oxygen thing that, you know, brain anoxia, the scary things. So it is a big difference. You need to stuck to column 1, awake intubation with non-invasive technique and without abolition of spontaneous ventilation. Then the first option here, so this is, as we mentioned, difficult ventilation, difficult intubation, difficult with the patient cooperation or consent, or difficult with tracheostomy. Just repeat the first few slides, and then use of non-surgical airway, spontaneous ventilation, and awake intubation as a preferred choices. This is number 1 choice because it will give you a lot of time. Then the first thing, if it's predicted difficult intubation, we do awake fiberoptic intubation. If it's successful, confirm the tube placement. If it's failed, either we cancel the case or consider of other options or surgical airway. If we think from the start it's very impossible to do, for example, one of the patients, we've had very huge tongue. We've tried, there is no airway. We just did awake tracheostomies, which is a solution. Those are the options: mask, local anesthesia, intubation attempt after, like if the patient is uncooperative, you think it's borderline, but the patient is uncooperative, you could induce anesthesia. That will be second, especially if you pushed. Of course, this might option in the ICU. You cannot cancel cases in ICU. So this is only in anesthesia or semi-elective cases. So when do we be in these cases? You know, difficult airway, anesthesia. We could be there from 3 roads. We did not know it is difficult. We just gave muscle relaxant and then it turned to be difficult. Or sometimes even in the best assessment you might be sometimes rushed, inexperienced, your assistants, your bad luck, you did do something wrong to your mother, to your wife, to your somebody da alayk. It happens. It happened to any, it could happen, okay? So unanticipated difficult airway, you just can't say I could prevent it. Or the patient is uncooperative and they will not cooperate. Mentally retarded, hypoxic, car accident. So if intubation is successful, the first intubation, you celebrate, everything is okay. If it failed, what should you do? If your initial intubation failed, what should you do? So oxygenate, try to ventilate. So if you try to ventilate and it did not work, like what? Could you please, just for the time, raise your hand and say yes, you saw it, okay? Call for help, okay? LMA, laryngeal mask airway.
Take a deep breath and think what you do.
Okay, take a deep breath and then hope the patient will take a deep breath. But that's very important, yes. Yes, you have to keep your head up, okay? What else? Sorry? My son. Video assist what? So now we said you try to intubate and you could not. Then you go to do mask ventilation, okay? So if mask ventilation is successful, you go to the green zone. If the mask ventilation is not successful, you go to the red zone. So cannot intubate, cannot ventilate, that's the red zone. If you can't intubate and can ventilate, it's the green zone, okay? So the first thing, okay, let's just go back in a slow motion. You try to intubate and you cannot. And now you want to ventilate and you cannot with the face mask. What should you do? I just want to know your answers for ventilation. LMA, that's number 6. What else? That's number 20. Tracheostomy number 20. Sorry? I'm saying for ventilation. Bougie, that's number 72. Now I'm saying about ventilation. Because we said patient will not die because of intubation. Patient will die because of ventilation. Cricothyroidotomy, that's number 20. I want number 2, number 3, number 4. Okay, Alhamdulillah. Adjust patient head. Reposition the mask. Airway, oral airway. Nasal airway after decongested. What else? Sorry? هذا بعدين. Okay? 2-hand ventilation. 2 people ventilation. Those are all important steps. Okay? You have to do this. Okay? These are 5 or 6 steps. And you need to have these ahead of time. If you don't have it, we'll come to the options. Okay? So what are the options if you can't intubate and cannot ventilate? What should you do first? 2-hand airway, nasal airway, and then you consider LMA and other things. Okay? If it failed. Okay, so you cannot intubate and you could ventilate. What should you do now for the intubation? What are the options for intubation? Now I could not intubate first time, but ventilation is okay. So what are the options? Laryngeal mask, that's number 4. Another trial, the same way.
Other person.
This is the most single step. The most wrong step is to persist to intubate with the same technique. You have to change something. A lot of cases, patients die because they cannot intubate, and then they can't ventilate, and they go the Indian movie, you know? I mean, or the cowboy movie or Daracola or whatever, a bad movie, okay? Scary movie. So this is very important. Cannot intubate, can't ventilate, you do not go again and do the same step. So we've talked about options. Now you need to intubate different ways. And now we're talking about the different ways. What are these different ways? So we said we could intubate through LMA, fiberoptic intubation, fast track. خليهم شوية كده، خليهم يصحوا، لأن في بعضهم صحيين. Cobra, glidoscope. What else? What are other options? Covid tube, CMAC. This is number 20. CMAC, bougie. What else? Where are the nurses? They're beating you here. Where are the? Wake up. I'm saying about intubation now. McCoy. You know McCoy? This is a laryngoscope with moving tip. Okay. What else? Retrograde intubation. What else? Pollard scope, nasal, fiberoptic, nasal trach light. Okay, what else? Airway scope, tracheostomy, air track. So if we have a board here, I will write for you 25 or 30 options that you could do. Of course, very important, 3 things that you did not yet mention.
High frequency is ventilation.
No, for intubation. I'm talking about for intubation now. Excellent. Change the type of the plate and change the size of the plate. If you're using straight, curved. If you use curved, straight. We talked about Miller. And the size. If you use 3, use 4. If you use 4, use 3. And change the neck position. Okay, the neck position is very important because the patient might not be in sniffing position, so you optimize. So you need to consider all these options. What make an option for you? Okay, I know 25 options. You know 30 options. He knows 15 options. But when the things happen, what make an option a good option for you?
Make what you are familiar with.
Okay, you need to be familiar with, so there are 4 conditions for any option for your options, to be your option. First, you have to know about it. You need to be familiar with it. This is number 1. Number 2, sorry? Experience, meta. When? At the time or before?
No, you should be proficient before.
So this is number 2. You need to be proficient and able to use it in peacetime, before difficult airway comes. Number 3, you need to have it available, not at the office of the director. He's the big boss and it's expensive and he lock it at night. So it's useless. Even if you know I'm proficient and you know it's there, so it's useless. Unless it is a difficult airway card that's movable, it is not useful. And number 4, no. And this is a story Dr. Mandura knows and people.
Good luck.
Good luck. This is, to get you out of the court. The patients, okay, I will not talk about this. I could talk without microphone. So, number 4, it's very important because, like when we work at Hajj, we were visiting the hospitals. And every time we go to one of the hospitals, we say, what's new? They say, we have kaleidoscope. Okay. We come second day, what they have? We have kaleidoscope in ICU and ER. Yeah, how are you? Long time no see. What you have? Kaleidoscope. Have you training? Yes. When Hajj started, one patient just died in the ER because of difficult airway. So we asked them, what did you do? They say, laryngoscopy. I said, the kaleidoscope. I said, oh. Because they had it in the place, but they did not have it in the right place in their mind. If you don't have it in the right place in these 5 minutes, if you don't have it located, if I have difficult airway, can't intubate, can't ventilate, I will use this and this and this and this. And then the specific that make this equipment right in this case. Okay, what is the feature of the equipment and where should? If you don't have these 4 conditions, any option is not your option. It's something for the workshop, something to be nice, to be smart during rounds. It will not be option for you. So you have to have these 4 options for options to work. You have to have it. You have to know the indications and contraindications. You need to be proficient and you have to have it available and in your brain to be recalled at the right time. Is that clear? Yes. Okay. So after multiple attempts, so we said here you have to try one of the alternative approach to intubation. Sorry. So this is non-emergency pathway. This is the emergency pathway. Can't intubate, can't ventilate. This is the non-emergency pathway. So you have to use alternative intubations. If at any time mask ventilation become difficult, you could put LMA, and that could transfer between the red and the green zone in the difficult airway algorithm. Those are the options if either surgical airway, under anesthesia, or awaken the patients. So those are the options that we talked about. Again, what make an option, as we said here, only 9 or 6 options, but usually the options are so many. You just need to know them ahead of time. So this is the emergency pathway, so call for help. So what happens if you can't intubate and can't ventilate? What's the usual thing that happens to people?
Panic.
Yes, panic. And what after panic? You have to ask yourself, if you're a doctor, why I did not go to dermatology? If you're a nurse, what about outpatient nursing? If you are technicians, I mean, what about orthopedic? You know, who is the person who pushed me into this specialty? And then make special prayer for them? Okay? So, yeah. Okay. You're allowed to do that for 2 microseconds in your brain without anybody knowing. Because if you go in that mode and continue, the patient will die. So what you need to do, panic inside your heart, but in front of everybody, stay collected and calm. It's like you're praying to somebody, you know. It's just, unless you do that, believe me, the patient will die. But it's normal to panic. It's normal, and then say, okay, what are the options? What could I do smart here to take the patient and me out of trouble? Okay? Because if you continue in that thinking, the patient will be in trouble. Sorry?
We have limited time.
Yeah, so you could do that in 2 microseconds, and of course you could just come later, call that person and say, okay, why you push me here, you know? Who pushed me, you know? You could do that later, but this time, no. You consider about the options. So what are the options to improve ventilation at this time?
We should open the airway.
Open the airway by the 6-5 tools, and the other option at these times, very specifically LMA and oxygen. Is oxygenation and ventilation the same? What is more important? Does not count. You could fool me, but not this time. You know, after 6 o'clock or 3 o'clock in the morning, I could be fooled, but not during the middle of the day. Okay, who thinks ventilation is more important? Raise your hand. Oxygenation is more important. Raise your hand.
This is 2 different terms.
It's 2 different things. More important. Democracy did not win this time. It's the only time. Okay, we have to call Gaddafi here. Okay, Zanga Zanga. We are in deep Zanga Zanga. Okay, because patients, we know that the difference between oxygenation and ventilation is with ventilation is oxygenation and CO2 elimination. We know that patients tolerate and survive high CO2, but nobody could tolerate low oxygen. So, as we started before, oxygenation is way more important than ventilation. Ventilation is way more important than intubation. Is that clear? And the 3 is important. So at this time, the priority is to maintain ventilation. oxygenation, and that could be done with the techniques to improve face mask ventilation, LMA, combi tube, and transtracheal jet ventilation. Okay, cricothyroidotomy and jet ventilation. Those are here for oxygenation. And then we could try some other transtracheal jet ventilation, laryngeal mask ventilation, and combi tube. Esophageal, you know combi tube. Everybody knows combi tube. Okay. Sorry? They keep the secret, huh? Okay, so combi tube is a blind tube that you just push it. It could go either way in the airway. You test it. If it's not in the airway, it goes in the esophagus. There is another balloon. You inflate it. And when you inflate that, you could use in between fenestration to ventilate. I'll show you an example in a few minutes, okay? It's a special blind intubation. Is it good thing or bad thing? Is it good or bad? It's good and bad. It's good only in emergency. It's very bad because it's one of the equipments that you cannot practice in normal people. It's not part of routine care. Like LMA you could use for routine care. But combi tube is very destructive. The morbidity is very high. Actually it's disappearing because there are so many other choices now. But it's classical choice here. So those are the options to establish a definitive airway, tracheostomy, intratracheal intubation, or awakening the patient. So this is just to summarize. You have recognized difficult airway. You go for proper preparation of the patients. Awakening intubation choices. If that succeeds, you celebrate. You go for coffee, tell people a good story. That's good. And then you confirm the intubation. If the patient is not cooperative or unrecognized, and you find yourself here after induction of anesthesia with or without muscle relaxant, then you try to intubate. If fail, you try to ventilate. If you could ventilate, you are in the green zone, and then you consider choices. If you succeed, you confirm. If you fail, those are the options. If you can't intubate and can't ventilate, you are in the red zone. That's where you call, you put you there, or push me here, but you need to control yourself, and then you consider intubation choices. Remember, it's all about the choices. The more choices, the more options that you know, you have equipment of, you're familiar, proficient, available, and no good indication are the options for you. If that's successful, you confirm. Remember, patients who are difficult intubation are difficult extubation. So every time prepare, the same preparation during intubation is the same preparation during extubation. Because if the patient failed extubation, you could use the same tool again for re-intubation. This is your friends, you know. If you have time, enjoy time with your airway tools, because they're very nice, helpful, cool, interesting, and if you're not familiar with them, they will not help you at that time. This is the tall guy, the cool guy, this is the combi tube. Okay? So you could push it blindly, this go into the esophagus. If it goes to the airway, you ventilate through the first lumen. If that's no CO2, you inflate the other balloon here, and then you ventilate through the other lumen. The air comes from here, not from the tip. So it has two entries. Okay, we'll stop here. Any questions? This one? Cupped oral airway. Cupped oral airway. Yeah, I mean, there are now about 40 to 50 different equipments for routine and difficult airways. Of course, we cannot all cover in 1 hour. We just wanted to give you overview, as we said. Okay? Follow. Sorry?
If we cannot ventilate and we cannot intubate, how can we operate at that time?
So if you cannot intubate and cannot ventilate, what should you do? Okay, the first thing, if you say cannot the ventilation? Like, what are the steps for ventilation? If you put the face mask face, it's not moving. What should you do? Oral airway. If it's not, you double check the size of the oral airway. If not, put nasal decongested and put nasal airway. If that's still not working, you put 2 hands to open the airway and then ask somebody to ventilate. If that does not work, sometime in anesthesia, and we've seen these cases, even with long experience, you need 2 people to hold the mask and somebody else to ventilate. So those are deliberate 5 or 6 or 7 steps just to optimize ventilation. If that did not work, you could consider laryngeal mask airway or combi tube, or you could do needle cricothyroidotomy. Khalid?
From your experience, Doctor, why some patients difficult to put LMA, like difficult animation?
Difficult animation, very nice. Okay, because people are born and created differently. So the point is, the point I wanted, you do have so many options. Of course, it could be a problem with the technique, problem with the size, problem with the lubrication, or particular anatomy, okay, or the depth of anesthesia. It could be many things, or it could be just because we know this is shaped on normal cadaveric anatomy. Not everybody is like the cadaveric anatomy of that particular patient in which they took the mold from. So, but in a lot of patients, it's just what's needed. Any other questions? Okay. How are we doing for time? Okay. I'll just show you who ever did awake fiberoptic intubation. Okay. Why people don't do awake fiberoptic intubation? Sorry? Not familiar, scared, it looks scary, and they think it's torturing the patient, okay? I'll just show you how we do it, because, one thing that we do, for example, in my own practice, we do a lot of awake fiberoptic intubation. We do it routinely, so we make it look not a big deal. We might not have time for this, okay? So I'll just show you here with video some of the cases that we've done, because the key for may I ask you, because there is a patient here, I'll just ask you not to take videos, okay, during the video showing here, because there is a real recording from patient. So this is how we do awake fiberoptic intubation. This is a patient that had a mandibular mass resected. So this patient had resection of his mandible a few weeks ago. Now he's coming because the graft is dead. So they want to take a picture graft, and we just cannot do laryngoscopy. If we take laryngoscopy, we take everything, all his mandible out. So we need to use the nose, okay? So now we just apply local anesthesia to the nose, and also we do nasal dilatation with nasal airway. Huh? Yeah, this is awake. I'll just show you, it's not a big deal to do awake fiberoptic. We just, like for all these options, you just need to practice it. If you don't practice it, become good at it in routine times, when you have emergency, you can't use it. Okay, so this is the first step. So there is nasal airway with local anesthesia around it. And then we go with local anesthesia to the piriform fossa with a curved forceps. So what is the job of putting the oral airway or nasal airway with local anesthesia around it? What's the job? Sorry? So to anesthetize the nose, test the nose, dilate the nose, and prepare the nose for intubation. because we know the size that will go through that nostril, because it is the narrowest part of the airway is the nose. After the nose in adult, everything is good size. So that's why it's very important to prepare the nose. And we apply local anesthesia to the piriform fossa. So we go with a care forceps, talk to the patient, ask them to stick their tongue out, see that the patient have oxygen in between, that's step 2. So the patient have oxygen already installed or already fixed to their shin. And we go with this cotton to the piriform fossa that will provide anesthesia for upper airway, down to the focal cord. Sorry? 2%. Xylocaine gel, anything you have on the table. Sorry? Not focal cord. I go to the nerve supply. The nerve supply comes from the side of the larynx, from the pharynx, go inside and then go under the mucosa. So I go from inside on the mucosa, and that will anesthetize the terminal nerves. I don't see, it's curvature, okay? So we do this 2 times in each side. The first time the patient cough, the second and the third time the patient will not cough. Okay, so that's piriform fossa block. And then we go with the fiberoptic. Of course, for the nasal intubation, first we go through the nose, and then we go with the fiberoptic. And before we go through the focal cords, we inject local anesthesia through the fiberoptic itself. Is that clear? So we anesthetize the area after the cord through the fiberoptic under direct vision. So if we see the cord, we just put some local anesthesia. So we take the nasal airway, the dilator. Yes. This patient, I'm doing this for him the second time. So he's a frequent flyer. He has a Al-Fursan with us. Sorry? This is routine. I could show you 20 or 20 intubation is the same amount. It's if you are competent, if you're comfortable with it, that communicate to the patient. If you talk to the patient, if you listen to what I was talking to him, I was telling, of course I'm giving him a little bit of midazolam, just a touch, like 2 milligram, and then, talking to him. If your voice is calm to the patient, and you speak to them step by step, they will not be scared. But if you talk, we'll do this, it will hurt, you'll cough, of course they will cry. So if you do it a lot,
Keep a musical tone.
you need to communicate trust between you and the patient, and that comes by just having to do more, okay? Don't focus on anything, focus on my picture here, eh? Don't focus on the intubation. So the assistant is very important role, because he knows what he needs to do. Now in this case, because it's a long endotracheal tube, special to come through the nose, he's making straight for me. I have to give him very clear instruction, or he needs to know this step to make it straight, so I could go with the fiberoptic. He used to be a resident with us, now he's the medical director of one of the hospitals in Mecca. Now he's a big boss. I have to take appointment to see him. Dunya. So now we see the cords, focal cords, and once I see the focal cords, I just apply local anesthesia and wait for 1 minute for local anesthesia to work, and then go advance the endotracheal tube. 2% xylocaine. What are the problem of using 4%? Toxicity. Okay? And you make sure that the intubation did not cause him to go paralysis. So now the patient is intubated, the tube in place, we inflate the cuff, ask the patient to breathe, we listen, make sure the tube in good position. We just wanted to also to test to see the patient is cooperative or not cooperative. If this is neuro case, we just want to make sure the patient has good power and he's following command. Okay, so we could disconnect the patient and ask him to go in his back or his tummy and then position him, and after he's in position, we induce anesthesia. Okay, so it's doable. Fiberoptic intubation or awake fiberoptic intubation is not a big deal. You just need to do it. It's a good option because it gives you a lot of time. Is there any questions about either the videos? Sorry? Yes. It takes 5 minutes or 10 minutes if you do it quick. Of course, if it's easy airway, why you use it? If it's difficult airway, we are talking about difficult airway. If you give routine care, like induce the succinylcholine and whatever, then you have 5 minutes. If you don't intubate in 5 minutes, you write the certificates. You know this. So I'm not saying this you use for routine cases. But in my practice, I do this not for only difficult cases. I do it for all intermediate difficulty because I want to do a lot to be good at and to give chances for my team also to do a lot. Because when more people do it, it becomes easier to manage in difficult cases. Okay? I don't know what's the word in English, but in Arabic we say تتلكك عشان تعملها. يعني if there is a quarter indication, I do it awake fiberoptic. They call me chicken, they call me جبان، ما يعرفش يعمل لارنجوسكوبي، عادي. يعني نقطتين من زملائك الاثنين الزملاء اللي في القسم عادي يعني عادي. But you just do a lot of it. Sorry? Just when you see it with fiber optic, with a working channel, just push Zyrocaine through the working channel, inject through the focal cord. Okay? Directly at the cord. Because you see them, it's in front of you. Because if you want to see that, you have to pay extra. Yes. Yeah, I'm just, okay. Today, I'm not trying to show you vocal cords. I'm trying to show you the technique of, you're right, okay? But we can't do everything in short workshop for free. We have to give you ad and then tell you to come to the full workshop. This is marketing, okay? Okay, thanks. I don't want it to say it loud, but you forced me. Sorry? Because Jeddah غير. No, this is actually for maxillofacial surgery. We use this because they will operate for 5 or 6 hours in the face. So we call this north tube. It goes up. So once we connect, stay away from the surgical field. Sorry? Okay, good. That's good. The patient has normal lungs. Your point is good. But in anesthesia, patient with normal lung, I could just compensate for CO2 management with higher rate. I mean, if the patient, of course, if the patient have a problem with CO2 elimination or dead space, already he the question, what if you don't have fiber optic, what could you do for this case? So the same thing, you know, like if you do this and attach the CO2 port, you don't need the fiber optic actually. The fiber optic is just for, you know, like it make it easier. But once you push through the nose, once you are in the hypopharynx, you could just move the neck. There are 9 options to move the neck. There is no more. 1, 2, 3, 4, 5, 6, and 3 in the middle. You know, because if you think about the skull, if the tube is pushed through the nose and coming from the nasopharynx, what is moving the tube towards the larynx is the skull. Right? If the tube is coming from the nose to the nasopharynx, what moves the tube to go to the esophagus or the oral airway or the larynx is the position of the skull. You use the skull to guide. So if you use like this and push it and there is no CO2, you know you're in the esophagus. So you change the angle of the head and then push again gently, never push anything forcefully. Okay, we'll stop here. If you have questions or if you want to practice with these skills for the coming few minutes, we're here. Thank you very much for coming, and I hope this is